Hi, I'm Ed Pound, the Managing Director of the Operations Science Institute. Welcome to the Institute's series, 52 Weeks of Operations Science in 2 minutes. To be clear, we're not going to compress a year's worth of operations science into 2 minutes. Every week during this 52-week series, we will provide 2 minutes of powerful, practical operations science insights. If you are not already applying operations science, you're wasting money and resources. Supercharge your and your team's skills with high-value, low-cost operations science online certification. Welcome. Today we explore how St. Mary's Hospital used operations science to achieve cost reductions while increasing doctor and nurse satisfaction, all the while supporting their high standards of patient care. And this week it's a bonus. You get 3 minutes of operations science, not 2. If you want the full details, see the book Hospital Operations. Wally Hopp, a co-author, is one of the pioneers of operations science. St. Mary's is a large East Coast tertiary care facility. That means they do complex treatments like brain surgery and organ transplants. But they're facing a lot of financial pressures. Revenues are declining, costs are increasing, and the majority of their costs are nursing and staffing. The doctors, as in most cases at hospitals, are not employees of the hospital. Well, there's a beautiful nurse right there. Okay, I have to brag. That's my daughter. She's a nurse. But nurses cost money. You have to pay salary and benefits. St. Mary's had big expenses for overage and underage costs due to variability in demand. Overage costs occurred when nurses showed up for work and there was not enough work. They were sent home with pay. Underage costs occurred when there was not enough nurses on a shift, so nurses are called in from home on a premium. St. Mary's had a fairly standard scheduling system. Fixed patients required specific units. For example, heart attack patients have to go to the cardiology unit. Flexible patients could be sent to different units. Dehydration effects from chemotherapy is a flexible patient and can be sent to other units when the oncology unit is full. And they had a nurse float pool. More on that shortly. St. Mary hired some consultants who said St. Mary should decrease variability by smoothing demand so nurses could be more efficient. A reasonable idea. They recommended sending flexible patients to whatever unit was available and had low utilization. This resulted in patients being spread all over the hospital, regardless of their particular symptoms. Turns out the nurses didn't like the float pool either because they didn't know where they were going, who they would be working with, and what type of symptoms their patients might have. The demand shaping was not well received. Doctors had to walk all over the hospital to find their patients. Doctors and nurses worked with people they didn't particularly know. Nurses were unsure of what kind of care a patient might require. There was lots of lobbying, so the procedure was only followed 50% of the time, and there were minimal cost savings. Fortunately, the hospital CEO had some experience with operations science. He knew that variability requires buffering. The demand shaping was not a viable option. Medical care is a service, so only capacity and time are available for buffers, and time is not an option because we don't want patients waiting. So how to best use capacity? You remember there's this big hairy formula that basically says that adding a few units of capacity really tends to help reduce cycle time and increase efficiency. The black curve shows a high variability situation where there's high utilization and nurse wait times to get to patients are really long. They're not used very efficiently. A way to think about this is adding another unit of capacity really reduces cycle times. It basically decreases utilization and has a strong effect, particularly when you're at high utilization to start with. Adding a second unit of capacity has the same effect, but not as large an effect. Adding a third unit of capacity does get you a reduction in cycle time, but the effect is getting much smaller. There's diminishing returns. The solution? Limited flex capacity. St. Mary's had a number of options for providing flexible capacity with nurses, but they settled on one. Nurses were cross-trained to work on one or two adjacent units, not every unit in the hospital. This provided substantial cost savings. There were happier nurses, staff, and doctors, and they were able to maintain their high quality of care without overburdening personnel. Next week, we see how operations science offers billions of dollars of value in the engineering and construction industry. Please join us at the Operations Science Institute. Like, share, subscribe, and comment on this video. Create an account at opscience.org for more great resources. Both the account and the resources are free. Contact us at info@opscience.org for personalized training. The Institute will train and certify your own trainers for long-term sustainability in your organization. Get your own operations science online certification. Share your knowledge and inspire, energize, and sustain success for you and those around you.